Right, good evening and welcome to today's discussion. Our topic today is CKD, and if we still have the time, we may still touch on IBAN, right? So, um, I'll be sharing my screen now. So that we can see what- Okay, can you guys appreciate the screen? I hope so. Let me see if I can make it. All right. So, please, chronic kidney disease. This would be the outline: epidemiology, etiology, progression of disease, complications, and management, right? Professor Oniwe, definition, this will be the objectives. I think somebody is at the door. Dr. Harrison, you're welcome. Should there.
Thank you, Chief. Good evening, sir.
Welcome, Dr. Harrison.
Thank you, Chief. Good evening, sir.
All right, so definition and staging of CKD, epidemiology. Can you guys hear me? And are you seeing the screen? Hello?
Yes, sir.
Can you
We
respond?
can hear you, but the screen is not large enough.
No, you have to zoom in now. Put your phone in landscape mode, zoom in. Click on my name. That's where the screen is. Then you zoom in. Put your phone in landscape and see it well. Because my phone is also on landscape, so it's supposed to be bold. So definition and staging of CKD, epidemiology of CKD, etiology and risk factors, CKD progression, risk factors and biomarkers, complications of CKD, then non-dialytic or conservative management of CKD, with emphasis on management of hypertension and DM. So by way of definition, I think CKD definition is one of those ones that should have been used to by now, right? So CKD is 3 months. Anything that is greater than or equal to 3 months, any renal pathology that is greater than or equal to 3 months, minus the the tiny details of it. YCLT is any liver pathology that is greater than or equal to 6 months, right? So let's look at it now. CKD is kidney damage for greater than or equal to 3 months with structural or functional, they even say and or with structural and or functional abnormalities of the kidney, with or without decreased GFR, and manifested by either pathological abnormalities or markers of kidney damage, including urinary or blood abnormalities, okay, or abnormalities in imaging body. So what's trying to say is that you know, for you to say someone has CKD, it could be obvious, like the person has clinical features, signs, and all that. Or it could be on investigation that you detect it, okay? Or it could even be maybe structurally when you do further investigations you found it, or even post-mortem where you do a pathology. Let's say you took a renal sample or something, renal biopsy, and you are seeing evidence of the markers of CKD, right? Okay, so even blood and urinary abnormalities that you're supposed to find, like for example, you do um, what do you call it, urinalysis, and you find evidence of something that can show you CKD. Okay, You could make a diagnosis for CKD. So another alternative definition is when you have a GFR that is less than 60 mils per minute per 1.73 meters square for 3 months or more, right? I have some people knocking on the door. Um, a minute. Dr. Noya. Dr. MK. All right. So um, maybe if somebody's knocking, you guys can just abuse the person. Let me not waste time. Okay. So hope you can still see my screen. Anyway, so CKD was classified into stages based on the glomerular function rate, right? So let's see. At least we know there is stage one, stage two, stage three, stage four, stage five. Okay. So stage three has two subclasses, stage 3A and stage 3B. So let's go through them one by one. Remember that what's the normal GFR of a patient, of a normal patient? What's the normal GFR? Hello guys. What's the normal GFR? Hello, can you hear me? Hello? Can you guys hear me? Dr. Noya, are you there? Hello? Hello? Can you hear me? Hello guys? Hello? Hello? No, no, they hear me. I just dey talk hello since nobody dey talk anything. Can you hear me? Unmute yourself and talk.
Hello, good afternoon, sir. Hello.
Dr. Molola, welcome. You guys should unmute yourself. Let me be sure you are hearing me. It just feels like I'm talking to myself.
Hello. Hello.
you unmute yourself, Dr. Noya? Unmute.
Hello, we can hear you.
Can you hear me?
I can hear you.
Anyway, I'll proceed. Um, can you guys hear me? Why is nobody talking now? I need oral feedback. I need oral feedback because I will not be on this screen. I'll be in another place. So if you don't give me feedback, I cannot see what you're typing.
Hello. Hello.
Hello,
Can you
sir.
hear?
We can hear you and we can see your screen.
You guys can agree to it for agree.
Hello, sir. We cannot see your screen. Your screen is not visible, sir.
Okay. So these are the stages. Let me use mouth. The normal EGFR is supposed to be above 90, right? So from 90 to 120 is expected to be the normal EGFR, where EGFR means estimated glomerular filtration rate. You know, that initially in previous discussions we talked about the different ways of measuring GFR. So you mentioned that you could either use 24 hours urine creatinine, where you can calculate urine creatinine over serum creatinine and all those formulas. But there's also an alternative way where you just measure the serum creatinine, get the patient's age, get the patient's sex, you know, and then you calculate the the EGFR with different formulas. There's corporate gout, there's MDRG formula, there's CKD epi, okay, which is said to be the most accurate one currently. Okay, so when you do that, you'll be able to get the estimated GFR just from the serum creatinine, the age, the sex of the patient, right? And the race sometimes. So when you plot that, you will now know what the GFR is. Then you will compare that GFR to these values that you're seeing here. Maybe the patient has come with symptoms that is beyond 3 months. So you compare those symptoms. You compare the GFR reading with what you're seeing here on the table. So if it's above 90, that means patient is still, GFR is still normal. But you can find some evidence of functional or structural abnormality of the kidney. Where is this one? You can find some structural or functional abnormality of the kidney. Uh, we regard that as still the early stage. This one, kidney damage with normal or increased. So, for example, let me give you an example. In diabetic nephropathy, the early stages of diabetic nephropathy, there will even be increased EGFR. So that's to tell you that even though the EGFR is normal or even increased, that does not mean that the patient is totally normal. The patient has 1 plus of proteinuria with normal EGFR. It's going to progress further if you don't manage it on time. That's stage one. Then stage two, you have kidney damage with mild decrease in GFR. So what they mean by mild decrease in GFR is GFR ranging between 60 to 89, right? So greater than or equal to 90, stage one, stage two, 60 to 89. Stage 3A, we have mild to moderate decrease, while stage 2B is uh, uh, moderate to severe decrease. Okay, so we have 45 to 59, then we have 30 to 44. So severe decrease in GFR is 15 to 29. That's like the last place before you now enter the kidney failure. So kidney failure is anything that is below 15. And this kidney failure is also known as end stage renal disease. So once a patient enters end stage renal disease, in fact from stage 4, patient should be on like dialysis. Okay, patient should be on dialysis. Patient should be planning towards renal transplant. Once patient enters stage, you know, irreversible stage 5, okay, then patient should have definitely have that renal transplant. Okay, so those are some of the things about staging of CKD. Then how do you detect, kidney damage? These are the markers. There's albuminuria when you do albumin creatinine ratio greater than or equal to 30 milligram per millimole or greater than or equal to 30 milligram per gram. There's also other variables, urine sediment abnormalities, electrolytes, and other abnormalities. So if you start getting high potassium, abnormal phosphate, all those things, calcium, these are all the things that you measure when you're suspecting a patient has renal function abnormalities. So you do serum electrolyte, urea and creatinine, serum calcium, serum phosphate. Okay, so you expect an increased calcium and reduced phosphate, or is it the other way around? Okay, so um, abnormalities detected by histology, structural abnormalities detected by imaging. It could be from imaging, it could be like ultrasound scan. Let's say use an ultrasound scan and you found bilateral shrunken kidneys, okay, with scarring and all those things, which suggest chronic glomerulonephritis, okay, or hypertensive nephropathy or hypertensive nephrosclerosis. All those things are possible features. Then history of renal transplant, of course, is a marker. So if you see a patient and you get a history, the patient had renal transplant in the past. It's already a matter of kidney problems. So um, in this graph, basically they're trying to plot the GFR and match it against existent albuminuria categories. So albuminuria category has A1, A2, and A3. Um, A1 is mild, normal to mildly increased albumin. Okay, we have between 3 and 30 milligram per gram. Okay, or less than 3. That's just mild albuminuria. Then moderate albuminuria, you have 3 to 30 if you are measuring in milligram per millimole, which is like the popular system. So 3 to 30. Then anything above 30 is severely increased, right? That will give you like 3 pluses of protein in the urine. So you're now matching those things. You can see the green zone, which is like the safe zone. This place is green. You see the yellow zone, see the orange zone, then see the red zone, where you are matching end stage renal disease versus severe or moderately severe albuminuria. So these are some of the things that you note. Epidemiology, we know that CKD is a global health problem. Okay, so and we know it has a lot of burden on both the individuals and government. Then in places like Nigeria, where the health insurance scheme is not well defined, it has a lot of financial burdens on the patient, and that's actually the reason why the patients end up giving up. Because by the time someone has dialysis, I don't know what the cost should be now, but it was costing about, let's say, 30,000 naira for each session. And the patient is supposed to have like 3 to 4 sessions. To have adequate sessions per week, you can say patients should have at least 3 to 4 per week. So imagine having 30,000 times 4. Let me say 30,000 times 3. That's 90,000, approximately 100,000 by the time they buy other things that are associated with it, right? So 100,000 naira per week. How many people, how many families can afford to spend that amount? This minus the hospital admissions that they will still come for, investigations that they need to pay out of pocket, and medications, of course, that they still need to pay out of pocket. So you see, by the time you multiply it, to be chasing 200,000 every week, which means it's 800,000, 600 to 800,000, or 500 to 800,000 every month. How many patients or how many families in Nigeria can afford that? So that you see why this is a very important disease. And prevalence between 8 and 16% worldwide. Um, so the prevalence is of course higher in low and middle income countries compared to high income countries, which is expected. Prevalence is higher in women, but men have a more rapid progression of CKD to end stage renal disease compared to women. And generally, for both men and women, prevalence of CKD increases with age, okay, which is expected, especially in high and middle low income countries. So, data from Nigeria, we have um, the prevalence of Nigeria, putting it at somewhere reports of end-stage renal disease between 6 to 12% of medical admissions are end-stage renal disease in Nigeria. So prevalence estimated to range from 2.5 to 27% depending on which region of the country. Then for young people, the age range is between 26 and 45 years. And one of the major factors too is that patients present late. Why would they present late? Because they are scared, not just scared in terms of of the disease itself. They are scared. One, okay, there are so many factors. Anyway, it's multifactorial. First of all, lack of information. They're not well informed, so the chances that they are going to present to, let's say, another place that is not the hospital before they come to the hospital is very high. So they are more likely going to go to the herbalist, go for herbal medications, get more nephrotoxins that they will take in, and even worsen their CKD. Then there are also high chances that they will go to traditional attendants. They will go to the pharmacies directly to go and get NSAIDs, right? They'll go there, they'll say they have pain. They'll give them NSAIDs, which will further worsen the condition, right? They'll still go to nurses, I don't know, local nurses, they'll still go without going to the hospital. So eventually they are going to present late. That's one. Okay, I even forget, they'll go to religious centers, they'll go to the pastor, they'll go to the whoever, the healers, right? So that they will heal them. Eventually, by the time they finish their money there, they will now come to the hospital, right? As end stage renal disease. So you see, there are so many reasons why they present late. Then when they eventually come to the hospital, they are scared. Financially, they have to pay out of pocket, which is not going to be easy as well. So let's look at other etiology. Classification of the etiology. Can say can classify it based on congenital and inherited, where you have congenital causes include ADPKD, Alport syndrome, Fabry's disease, tuberous sclerosis, oxalosis, a lot of diseases, but not ADPKD, especially very important. Alport syndrome is also there. Um, then vascular diseases like hypertension, which will lead to hypertensive nephrosclerosis, renovascular diseases like renal artery stenosis. Please, somebody should accept the person that is knocking on the door. Vasculitis, like small and medium sized vessels vasculitis, renal vein thrombosis. Okay. So other etiologies. The other time we discussed glomerular disease. So there are primary glomerular disease, there are secondary glomerular disease. So from primary, ranging from minimal change disease, IgA nephropathy, membranous focal segmental
Hello,
nephrosclerosis,
Chief. We can't see your
all those
screen.
things, glomerular sclerosis,
Hello, Chief.
all of them are primary glomerular
Hello,
disease. And
Chief.
secondary ones like diabetes, SLE,
Hello, Chief.
IVAN, hepatitis B and
Your
C,
screen is not
nephropathy,
visible, sir.
connective tissue disease, all those ones are secondary causes of
Your screen is not visible, sir.
and even
Hello, sir.
RPPN, rapidly progressive pulmonary necrosis, different kinds of neoplasia, amyloidosis, thrombocytopenic purpura, swelling, all of them endocarditis. So other causes, we have tubulointerstitial disease like chronic pyelonephritis, reflux nephropathy, and analgesic nephropathy. Those are tubulointerstitial renal diseases, right? So um, we have tuberculosis, multiple myeloma, and toxic nephropathy, including herbs and aloe vera and all those things that people like drinking, agbo, agbo, and so on and so forth. So obstructive uropathies like calculi, those are like post post renal CKD. So calculi, prostatic disease like BPH, prostate cancer, pelvic tumors, retroperitoneal fibrosis, cystosomiasis. Then, of course, there's the unknown etiology, okay, the ones that we cannot really, idiopathic, like we say in medicine. So, common causes in Nigeria, we have hypertension is one of is the commonest cause in Nigeria, right? Of CKD. So, we are going to compare Nigeria versus, let's say, US. Hypertension, chronic glomerulonephritis is quite common in Nigeria, meaning that it's an infective process. People that had possibly, what do you call it, streptococcal sore throat, maybe when they were kids, right? Which we know that is highly likely that they're not going to be getting the actual treatment, right? They will not get the antibiotic treatment. So this thing will just resolve by itself without getting actually treated. Okay, so and when this happens, there are chances that some of the residuals can lead to renal damage later through molecular mimicry, right? Then diabetes mellitus, HIV infection, and toxic nephropathy. Like we know, people drink a lot of herbs. So it means if you are taking a history for a patient with renal disease in Nigeria and we are not capturing these causes, this at least this top five causes. Now recently we have COVID-19 as a major cause. So if you're not capturing these causes, then you haven't really done anything useful for the patient. Then in the US, diabetes mellitus tops the list, followed by hypertension, CGM, and cystic disease. Then COVID-19 coming in there. So etiology, the list of causes is not exclusive. We've already talked about it. So just know that other things that may be important include family history. Just the usual cardiovascular risk factors. There's the modifiable, there's the non-modifiable. So non-modifiable includes age, sex, okay, ethnicity, like race, genetics, family history, uh, things like modifiable risk factors like smoking, alcohol, hypertension, diabetes, obesity, sedentary lifestyle. All these ones are modifiable. Even socioeconomic status are modifiable. Obesity is modifiable. Okay, dyslipidemias modifiable as well. Nephrotoxins, the use of nephrotoxins, active kidney injury in the past. All these ones can be said to be modifiable. But family history is not modifiable, right? Genetics is not modifiable. So sickle cell disease is also another important disease, being that it's quite prevalent in Africa, right? So the progression, you know, the rate of progression for different types of renal disease varies. So, for example, if you have um, diabetes mellitus or diabetic nephropathy, it's one of the highest or fastest progressing renal disease. Okay, for example, it can progress at the rate of 10 mil per minute per year. So that's quite fast. So if you have if patient is at 90 and the patient is going at 10 mil, it means in the next 7 to 8 years, patient is already at end stage renal disease. Okay, so it progresses very fast. And things that will affect the progression include all those the amount of proteins that is being dissipated in the kidney, the management of the underlying conditions like hypertension, diabetes. So if those conditions are not being managed well, progression can be faster as well. Proteinuria is not being managed well, progression can be faster. You know, infections and all that. So so It's said to be rapid if there is sustained decline in EGFR more than 5 mils per minute. So you can see that diabetes is quite fast in this progression. So most patients in CKD stages 3 to 5 will progress to end-stage renal disease. So one patient don't enter stage 3, just know say it's just a matter of time. So start preparing the patient for possible renal replacement therapy, which can include dialysis as well as so the goal of treatment in those stages when you start getting to stage 3 is actually to delay the, the progression to end-stage renal disease. The reason why you want to delay it is that you don't want to transplant the patient. You want to delay the transplant as much as possible because transplant is like the organ of all the treatment you are going to do. So you don't want to transplant early. You want to transplant very late so that because even the transplant itself has a lifespan, approximate 5 years lifespan, right? So you want to transplant as late as possible so that you can delay the inevitable. Then okay, I've already talked about this one. So you need to monitor with progression with markers. Um, I've already talked about these things. Non-modifiable risk factors and modifiable risk factors. Note this APOL1 gene. Okay, that's one of the things that you find in blacks that predisposes them to essential hypertension that
We
does not
cannot see the
respond
screen.
to common medications except amlodipine. Okay, and also this is one of the genes that predisposes them to hypertensive nephrosclerosis. So this gene is very important in blacks. Okay, end stage of course. Then biomarkers that are very important for CKD patients. Um, Traditional biomarkers include creatinine, cystatin C, and proteinuria. Okay. The novel biomarkers, there are new biomarkers. I've talked about this before. You need to read up this topic, these biomarkers, because it can come in your MCQs. Uromoduline, kidney injury molecule, that's KIM1, fibroblast, growth factor 23, FGF 23, neutrophil gelatinase associated lipocalcin, NGAL, KIM1, soluble urokinase type plasminogen activator, super. Okay, so super, new mode, KIM1, FGF23, NGAL. So these are all novel biomarkers that have been recently discovered that are related to kidney um, CKD. So uremia, some of the complications of CKD. Okay, we have uremia, malnutrition. Of course, we expect uremia to occur. Malnutrition, of course, patient is going to be losing a lot of protein in urine, so you expect the patient to be hypoalbuminemic. And a patient that is hypoalbuminemic is never going to look normal. The patient will look malnourished, will look like a kwashiorkor patient, anasaka, generalized edema, because you have altered the balance between serum proteins and the tissue, right? So, fluid and electrolyte imbalances, as you expect. You have abnormal salt and water retention, hyperkalemia, uh, hyperphosphatemia, hypocalcemia, all those stuff, right? Then, and it's this hypocalcemia that will lead to mineral bone disease. And you know that one of the functions of the kidney is to produce or to help in the metabolism of vitamin D3, which is also going to help in the metabolism of calcium and phosphate, right? So, if for whatever reason the kidney is damaged, you'll be having this problem. And also, one of the functions of the kidney is to produce erythropoietin. I think produces about how many percent? Is it 90% or 10% of erythropoietin? So you see that when the patient has renal CKD, this function of the kidney will be impaired, which means that there will be reduction in erythropoietin, and erythropoietin is the hormone that leads to production of red blood cells. Please, somebody should accept the person. Then, which will lead to anemia, right? Then metabolic disorders like gout, you are going to have hyperuricemia because of the loss of function of renal filtration abilities, right? So you can have gout, lipid metabolism abnormalities. On the cardiovascular system, you patient can have MI, cardiac failure. There's cardiorenal syndrome, renal cardiac syndrome, renal hepatic syndrome, hepatorenal syndrome. All
Dr.
those things
George, your
can
screen is not showing.
a loss of function of one major organ can lead to loss of function of other major organs. That's what it means. So if you have a kidney problem, it can lead to heart problem, it can lead to liver problem. If you have a liver problem, it can lead to heart problem, it can lead to kidney problem, it can lead to brain problems. Okay, so they are all linked to one another.
Hello,
So
sir. We
pericarditis is
cannot
also
see
one
your
of the
screen.
Dr. George,
can
your
even be
screen is not
the first
showing.
presentation of a CKD patient. And so okay, can even be a first presentation of a CKD patient. Then CNS, um, peripheral autonomic neuropathy, restless leg syndrome, encephalopathy, decreased immunity, anxiety, depression. These are all possible symptoms of CKD. Then dialysis, non-dialytic management of CKD. These are the
Well done, Dr.
investigations.
George. Well, we can't see your
We have
screen. Oh.
urinalysis, uh, hematuria, hematuria. When you do a urine analysis, you can see hematuria, proteinuria, glycosuria, which is glucose in urine, specific gravity of 1010. Anything below that is a problem. Then urine microscopy, you can see granular cast, red cell cast, 24 hours urine clearance, you see ACR increase. Um, do blood tests. So reduce calcium, increase phosphate, increase uric acid, uh, anemia, ESR, depending on the kind of disease, you can have elevated ESR. Let's say it is, what do you call it? SLE that's causing the problem. You can have elevated ESR. Or maybe in an acute on chronic CKD, you can have elevated ESR. So electrolytes, urea and creatinine, you can use it to calculate the GFR. So it's going to be lower than normal. Then lipid profile, you expect some of those lipids to actually be increased. You do your viral studies, serum albumin, see hypoalbuminemia, viral studies, HIV, hepatitis B, hepatitis C, other ancillary tests include uh, anti-nuclear, depending on what you're suspecting. Multiple myeloma, you do, what's that test that you do for multiple myeloma patients? You do serum immunoglobulins, right? Anti-nuclear antibodies, double-stranded DNA in SLE, dsDNA. So radiological can do renal ultrasound scan, where you can see a wide range of features depending on the type of you know, kidney problem you are suspecting. So you can have something like bilateral shrunken kidneys, epidemic kidney because of medullary differentiation, this classical CGM. Okay? Hydronephrosis, okay, in those with obstructive uropathies. Then plain X-ray can see stones if it's post renal stones, right? CT scan of the retroperitoneal fibrosis can use it to diagnose something like that, and even tumors, right? MRI of renovascular disease can see renal vein thrombosis. Can do this IBU, although it is seldom done because if patient is already in CKD, this the use of this contrast, which is going to be required in this intravenous urography, wasn't the condition. So you have to be very careful with doing it. Go ahead to do your ECG to the echo to rule out cardiac because renal presentation also mimics. I've seen patients where you you'll be clacking, you know, you'll be asking yourself which one is it? Is it cardiac? Is it heart failure or is it renal? Is it cardiac? Is it renal? You have to be very, very, hyper focused in your history to actually catch which one it is until you do investigations, right? So renal biopsy may enable you, but there are indications for renal biopsy. It's not every patient that comes that you are going to do renal biopsy for. The management of CKD. Um, Identify and treat underlying causes. Okay. Example, if it's drugs, you withdraw the drugs. If it's tuberculosis, you treat it. If it's diabetes, you manage diabetes. If it's hypertension, you manage the hypertension. Whatever it is that is the initial cause, you try to withdraw whatever it's causing it. Let's say the patient is on herbal medications, you stop the patient from taking it. Analgesic nephropathy, you stop the patient from taking those NSAIDs, right? So that's the first step. Then you start and tackle the reversible factors that can worsen the renal function. Okay, so like hypertension, all these things will worsen. Because we know that CKD, hypertension is a feature of CKD. See, hypertension can cause CKD, CKD can cause hypertension. So it's a vicious cycle. That's why you see in patients with CKD, they have this resistant hypertension that you need to treat with more than with three or more drugs. Okay, three or more, most times four, five antihypertensives on one patient, and you are still barely managing to even control it. So it's even only dialysis that can normalize your blood pressure most times. Then UTI, if patient has UTI, you manage it. Nephrotoxin drugs, you stop. Hypertension, you manage hypovolemia. Uh, Dietary management, control calcium and phosphate. Okay, so you need to supplement calcium externally and also give external vitamin D, D3. Okay, will be there's this Oreos, the Oreos. There's this brand that comes with mixture of calcium, 600 milligrams, and 400 international units of vitamin D3. So you can give the patient one tablet of that per day. Then you supplement their their iron levels, right? It's either you use external erythropoietin. They also receive erythropoietin injections. Okay, uh, as soon as possible. Then judicious use of drugs. Monitor. You can give lipid lowering drugs like statins. If patient is a smoker, stop smoking. If patient is taking alcohol, stop alcohol. Anything you know that wasn't any risk factor that you picked up, they try to tackle it head on. So these are like the non-drug management. Then reduce the cardiovascular disease, manage hypertension, manage diabetes if it is there, manage anemia, manage electrolytes and mineral bone disorders. Yeah, because, um, watch out for CKD. Patients should also avoid, watch out for hyperkalemia. Patients should also avoid potassium containing foods and fruits like nuts, cashew nuts, especially banana, fruits like banana and tomatoes. They have a lot of potassium in them. So patients should minimally, so a patient should not take banana at all. You know. So that's one of the counseling that you need to give the patient. Dietary management. Uh, Okay, so you monitor the patient amenorrhea at least once annually, twice a year at high risk, and thrice a year for patients at very high risk. So, so this one is now talking about each of the risk factors one by one. If you want to manage a patient with CKD that is caused by hypertension or a patient that has CKD that has led to hypertension, you need to lower the blood pressure. Of course, you low salt, low dietary salt intake, less than 2 grams of sodium per day, or less than 90 millimole of sodium per day, or less than 5 grams of sodium chloride per day. All these are values. Cessation of smoking, physical activity like brisk walking, swimming, for at least you know 30 minutes 5 times per week. That's 150 minutes per week. Weight loss for the overweight to achieve a BMI between 20 to 25 kilograms per meter square. Moderate alcohol consumption, diet rich in fruits and vegetables, high fiber, low dairy products. Okay, so these are the recommendations. Apart from the drugs, obviously, you like to start on ACE inhibitors, being that they also have anti-proteinuric effects. So ACE inhibitors or ARBs are very good in this case. Mineral corticoids like aldosterone, spironolactone also have a role to play. Management of hypertension. Uh, the target should be 130 over 80. So reduce the risk of cardiovascular uh, disease, right? CKD is associated with higher risk of coronary artery disease, myocardial infarction, heart failure, atrial fibrillation, CVA, stroke TIA. Need to reduce risk of cardiovascular events. So you need to reduce all these risks. The statins, cessation of smoking, and keeping the blood pressure below 140 over 90. Usually we use 130 over 80, so that we give it a gap. So for diabetes, still similar with the management of hypertension. You just need to use ACE inhibitors to reduce the proteinuria, because diabetes has a lot of proteinuria is the first sign. Microscopy can start as microscopic proteinuria before it becomes macroscopic proteinuria. So uh, it's usually the first sign of diabetic nephropathy. So you need to tackle it head on. Then, of course, manage the diabetes, stabilize the patient's blood sugar. HbA1c should not be above 7%. That's when you know you are managing it properly. Okay. So you can even use, even if you decide to use a higher target of 7.5 or 8, it's still good, but just try to keep it between 6.5 7. That's where that's the sweet spot. Then the best drugs for patients that have CKD as well as diabetes. There's this SGLT2 because do you know any example of such drugs? And also glucagon-like peptide antagonists. There's this canagliflozin. So you see a patient with CKD, or sorry, heart failure and diabetes, or CKD and diabetes, all those things. Those SGLT2 inhibitors, they are very nice. They are new. They are new drugs. Okay. So dietary management, low protein diet. Okay, keep at 40 grams per day to reduce blood urea, symptoms of uremia, and slow down the progression. Because the more the protein load you are giving to the kidney, remember the function of the kidney is to filter the blood, remove urea, remove all those things, the waste products of metabolism. So urea is one of the major ammonia is one of the major waste products of metabolism, which is going to be converted to urea, right? So the more you load the person with proteins and all those things, the more work you are giving to the kidney, which will increase the likelihood that the kidney will progress to end-stage renal disease very fast. So restrict sodium intake when patient has edema or hypertension. Potassium restriction when there is hyperkalemia. Use of iron exchange resins is also there. Dietary control in those with hyperlipidemia. Of course, you need to avoid all those sugary foods, sugary products. The usual advice: avoid Pepsi, Coke, avoid cakes, sweet stuff, avoid adding extra sugar, reduce carbohydrate intake. You um, what are all those advice? Eat lots of fruits and vegetables. High fiber diet. Okay, so these are the management. So if you find anemia, you manage anemia. Okay, patient often has normochromic, normocytic anemia. So hemoglobin level is preferable to so anemia with erythropoiesis stimulating agents, okay, such as exogenous erythropoietin, hypogen. Control calcium, serum calcium, and phosphate. Replace them. Give phosphate binders. So calcium supplement, vitamin D supplement. Give phosphate binders. Calcium mimetic products are also useful, like calcinamet. Emerging strategies: we have uric acid lowering therapy, like Renal, bicarbonate therapy. Acidosis is implicated in progression of renal disease. So vitamin-based therapies such as vitamin D receptor blockers are also useful. Thank you very much for listening. Any questions? Have any questions?
Hello, good evening, sir. Hello,
Hello?
hello, can you hear me?